We have amidst us Dr. Surajit Giri from Assam, India. He's a governing council member of Indian Society of Anesthesiologists. He was the honorary secretary of the Indian Medical Association, SIPSACA. He's a critical care physician, palliative care physician, and a snakebite social activist. Presenting to you, Dr. Surajit Giri.
Good evening, ladies and gentlemen. I have been assigned PNS guided blocks around elbow, and I am conveying greetings from Sipsagar, Assam. I declare that I have taken consent from patient and the family for photography and videography, and I do not have any conflict of interest. Ladies and gentlemen, the elbow blocks were actually used to uh, for the primary block if the primary block is patchy and partial. So our elbow block is given to augment and supplement the primary block like axillary block or the supraclavicular block to complete total anesthesia and analgesia to the patient. Now, whether the elbow block can be used as a sole anesthetic technique, let's find it out. Ladies and gentlemen, at elbow level, we can block 6 nerves: the median, the radial, the ulnar, the medial cutaneous nerve of the forearm, the lateral cutaneous nerve of the forearm, and posterior cutaneous nerve of the forearm. That 6 nerves can be blocked at elbow level. So you can see this is the medial cutaneous nerve of the forearm, this is the lateral cutaneous nerve of the forearm, and this is the posterior cutaneous nerve of the forearm. So these are the cutaneous nerves, and this is the myotome. You have to know about the forearm that this is the median and this is the radial, and this is again median and this is radial. So you have to know this, the dermatome, you have to know the myotome, you have to know the osteotome of the forearm area. Now question is, can we do surgeries on sole elbow block? Ladies and gentlemen, yes, we can do. Our indication is for the forearm surgery, for volar pairing, for the hand and the finger surgeries. Now, how I do it? So this patient is coming for the radial fracture, ladies and gentlemen. So our technique is elbow block. So this is the elbow crease. Elbow crease. This is the biceps tendon, and we are going 2.5 centimeter lateral and 2.5 centimeter up. So that is the needle insertion point for radial nerve, ladies and gentlemen. So we are taking 25 mm, 50 mm stimuloplex needle, and our end motor response should be the finger extension. Now, wrist extension should not be taken as an end motor response. Our end motor response is finger extension or thumb extension. So we have manipulated the needle so that the twitches does not appears less than 0.3 milliamps. So we have adjusted the needle so that the twitches appears at 0.3, and then we are depositing 7 ml of local anesthetic for radial nerve block, ladies and gentlemen. And when you inject the drug, and always inject yourself, and you can feel the freeness in injecting that local anesthetics. So once I injected local anesthetic, the twitches disappears. So that is radial nerve, ladies and gentlemen. Now for the median nerve, you see this is the brachial artery. You go just medial to the brachial artery and insert the needle there, and we look for the finger flexion. So again, the end motor response should be the finger flexion, not the wrist flexion. So wrist response should not be taken as an end motor response. You can see that I am getting the flexion of the finger. Again, I am injecting myself, and you can feel the freeness of the injection, and you can deposit now the 7 ml of local anesthetic, and you can see, so with the sole elbow blocks, we are doing the open reduction and internal fixation for the radial shaft fracture, ladies and gentlemen. Now dermatome is blocked, myotome is blocked, osteotome is blocked properly. Is whether this median and radial nerve block alone can be sufficient. Answer is no, ladies and gentlemen. There is something tricky part is there. And that is what we have talked about, the cutaneous nerve, ladies and gentlemen. So when you have injected the 7 ml of local anesthetic for the radial nerve, after injecting the local anesthetic, when you are withdrawing the needle, you just infiltrate the that 3 to 4 ml of local anesthetic in fan-shaped manner, especially in the medial direction, to block the lateral cutaneous nerve. And this is, I'm getting the finger flexion for the median twitches, and then I have deposited 7 ml of local anesthetic. And when I'm withdrawing the needle, at that moment I am depositing 3 ml of local anesthetic to block the medial cutaneous nerve of the forearm. That will complete the anesthesia and analgesia for forearm surgeries, ladies and gentlemen. Sometimes you need to block the ulnar nerve also. And here the position is, you can see, this is the position of the hand, and this is the ulnar groove. You should not inject at the ulnar groove. You always go 1.5 to 2 centimeter above the ulnar groove and insert the needle perpendicularly, and there should be the apposition of the thumb and the little finger. That indicates that I'm stimulating the ulnar nerve, and I'm depositing only 5 ml of local anesthetic there, which efficiently blocks the ulnar nerve. Now you can use this block for the finger surgeries with tourniquet. Surgeon says I'm going to use the tourniquet, and definitely you can go for the elbow block, ladies and gentlemen. This question is posted for amputations of the index finger, and as it will be traumatic to the patient, that's why we have decreased the intensities as well as the frequencies of the current. And I am first injecting at the radial nerve response, I'm getting at 0.3 and depositing 7 ml of local anesthetic there. And our end motor response will be the finger extension. So once we got the finger extension at 0.42, we have deposited 4 ml of local anesthetic here. And that is the radial. And next you require is the median nerves. So here I'm getting the finger flexion, manipulate the needle so that I can get the twitches at 0.3 and deposit at 7 ml of local anesthetic. See, all dermatome, all myotome is blocked properly, and you do not need any extra cutaneous nerve block for the finger surgeries, ladies and gentlemen. So advantages of this elbow block is that you are away from the vital organs, you are away from the pleura, you are away from the other major structures, and it is a better patient acceptance. Because you see, when the patient comes for the forearm surgeries, and if you are giving a supraclavicular or axillary brachial plexus, this will blocks the arm as well as the forearm, which will causes inconvenience to the patient. So the inconvenience can be decreased if you go for the elbow blocks, number 2. And second thing is the cost effective. We are using as in daycare procedures. We give the block, we do the surgery, you put a patient for 2 to 3 hours and send them for home. And that is the biggest advantage, ladies and gentlemen. But the biggest disadvantage is that you cannot use the tourniquet. If the surgeon says I'm going to use the tourniquet at arm level, yes, you cannot use this forearm block, ladies and gentlemen. Other disadvantages I have to yet to get it. So to conclude, ladies and gentlemen, it is at the elbow, the blocks around the elbow is a primary rescue block, but it can be used as a sole block with cutaneous nerve block, and that we have described in the video. The finger response are a must, ladies and gentlemen. No wrist responses only as a rescue block. It can be used as a sole anesthetic technique as we have described. That is my conclusion. Thank you for patient listening.